Dear colleagues, dear participants, and first of all, I welcome you all. It's our second international webinar on this platform in the BRIDGE.International. And today we will discuss and debate about maybe most common and most debatable surgical treatment in urology, PCNL, because in the recent years, further technological modifications have led to miniaturization of the instruments, and these are now becoming increasingly used in adult patients with the advent of the mini PCNL, ultra mini PCNL, and microperc. The initial results are promising with the good stone-free rates, reduced risk of bleeding, and decreased length of hospital stay, and improved analgesia requirements. So we will today we will discuss it with three well-known surgeons from whole world, from Turkey, India, and Russia. And let me introduce our first speaker. I think he's don't need to introduce more, but because of the rule of our webinar, I will introduce him, Professor Janak Desai. I would say he's one of the worldwide mentor of PCNL, who spent a lot of power to develop the new techniques, new modifications on the surgery. He's the innovator of ultra mini PCNL. He's a past president of the West Zone Urology Society of India, who performed more than 30 workshops in the world. And today he will share his great experience about the fluoroscopic guidance puncture in PCNL. Dear Professor, it's your time.
The first step of PCNL, of course, is puncture. And I believe that puncture is a very, very important step. In fact, my feeling is that it's 75% of the job of PCNL is done when the puncture is well done. Because if the puncture is well done, the rest of the things is going to be extremely easy. So I bring greetings from India, and I'm speaking from my city of Ahmedabad, which is somewhere here on the western part of India. We are 1 hour north of Mumbai, 1 hour flight north of Mumbai. This is New Delhi, 1 hour 15 minutes southwest of New Delhi. And if I see the chart of the world, I almost feel like taking a big leap from Ahmedabad right up till Tashkent and say hello to you, Azim Dion. Unfortunately, traveling is very much restricted. We are a city with an international airport with a lot of multiple flights coming over, but everything is so very restricted. So I think shaking hands in person is going to take a while. So in the meantime, let's exchange ideas on the internet. Now, when I talk about fluoroscopy guided puncture, it's very important, very, very important to have all the things that I have listed here, a proper lead apron, because you are going to be exposed to radiation, lead glasses, because people who don't wear lead glasses, it is reported that they develop cataract earlier than they would otherwise do. A thyroid shield, because thyroid is pretty much on the path of the radiation that would hit, and it's a fragile organ as far as radiation is concerned. A radiation badge, which is mandatory in the hospital, so that you are aware of how much radiation is coming onto you, and if you have exceeded the safe dose, it's better to take it off for a couple of days or maybe a couple of weeks. Foot control always with the surgeon and not the technician. I put this point because I do workshops in some part of the Western world, particularly the UK. The technician is in charge of the IITV, the image intensifier, and he will put on the switch or put off the switch. So when the surgeon says on, and he would put it on. When the surgeon says off, he might be dozing around or he might be a little less attentive, and that radiation goes on. Whereas if the surgeon himself is pressing the pedal, it's exactly those few seconds that you require, just a flash, and you are done. a sonography unit in the operating room is a really helpful tool. We have always a sonography next to us. We do fluoroscopy guided puncture. We also do sometimes sonography guided, but the sonography is done very quickly for 2 minutes to scan the organs and to keep organs away from harm's way. You just know the lie of the colon, the lie of the liver on the right side, the lie of the spleen on the left side. If the spleen is very much enlarged and you want to do an upper calyx puncture, you may hit the spleen, or on the right side, you may hit the liver, and that might be catastrophic. And it is always good to have a 3D CT IVU. We all get our IVUs done, a CT IVU, but always insist that your radiologist will give you those 3D images also, and you can see that you can rotate the image beforehand. Before you take the patient into the operating room, you know exactly that this is the anterior calyx and this is the posterior calyx, because that sometimes is a confusion. So beforehand, you know that you are going to hit this calyx, which is the posterior calyx, which is our preferred calyx as PCNL surgeons. Now, in fluoroscopy, I would very much insist on two planes for precision, plane 1 and plane 2. And plane 2 can be obtained in two different ways. And therefore, there are two different techniques, the bullseye technique and the triangulation technique. So let me explain that. So plane 1 is the vertical plane, the 90 degrees plane. But plane 2, the second plane as we call it, is, as I said, bullseye or a triangulation technique. And let me first explain the bullseye technique. The bullseye technique, as it is known, because the torero in the bullfight wants to hit the eye of the bull. He wants to be very precise where his spear goes in to defeat the bull. So as a urologist, we want to hit the tip of the calyx, and the examination is with the C-arm at 90 degrees. It defines the medial vertical plane, the medial plane. Then the C-arm is rotated 30 degrees, and it provides the end-on view of the posterior calyx. So then when you rotate it on your side, the operating side, you are trying to align the tip of the needle to the tip of the desired calyx. So that is the bullseye technique. And if you see in a diagrammatic way, this is the vertical plane, and the needle looks like this. It shows the full shaft of the needle, and it tells you the direction. And when you move the C-arm towards you, you are trying to align the tip of the needle to the tip of the calyx. So that is the bullseye technique. Once again, this is the vertical plane and this is the 30 degrees tilt. But remember that when you bring the 30 degrees tilt and your fingers are holding the needle, you may get the radiation on your fingers. To avoid that, you can use a long forceps to hold the needle, and that will allow you to push the needle inside. Now, I will come to that point a bit later on, why I'm not a fan of bullseye technique. This is one of the points. But anyway, so if you see that you want to hit the calyx here, the vertical plane shows the needle like this. And when you move the C-arm towards you, you are trying to align the tip of the needle with the tip of the calyx. I'm repeating this again and again because this is exactly the bullseye technique. Plane 1, plane 2 towards you, and the needle, the tip is trying to be aligned with the tip of the calyx. Some people, they do a freehand technique. They don't use the second plane, just the plane 1, and with experience, they would push the needle in, and if it does not hit the calyx, they will come out and make a little deeper puncture. If it does not hit, they'll come out and make a little superficial puncture. So it's a freehand technique by using just one plane. Not a good idea. You already have the C-arm, so why can't you use the second plane? And what can go wrong with the freehand technique in fluoroscopy is shown in this small little picture. So this is needle B, which is going in the calyx, the desired entry of the calyx. But needle A on the plane, on the vertical plane, also will look as if it is going in the calyx, and so also needle C. They are all in the line of the calyx, but one is above the calyx, one is below the calyx, and they all look as if they are going into the calyx. It is only when you do the second plane, it is only when you do this that you realize that the needle A was actually going above and needle C was actually going below the desired entry of the calyx, and unnecessarily you were passing the needle again and again, and you were not going in on a single pass. So a freehand technique is not something that I would like to encourage. Though there are people across the world that they do a freehand technique. And when you do that, this is the possibility. You may go wrong and you go behind the calyx. You feel you are in the calyx and you hit a blood vessel. You may go through and through. People have gone through and through the lower calyx, which is the anterior calyx, and created a intrarenal hematoma, which of course is not a good idea. So when you do all this PCNLs over the years, when you reach the end of what you should know, you will be at the beginning of what you should sense. You start sensing that that is not a good idea. Precision and trying to enter on a single pass, preferably, is what is a good idea. Now let me run a video. Let me run a video which shows how I bring in the steps of fluoroscopy guided puncture. So there are 4 points. Selection of the skin puncture site from where you will enter. You will use 2 planes of the IITV, as I said, and sonography surveillance before you start the puncture. And of course, you have to hit the tip of the calyx. I would not like to go by the side or directly onto the pelvis. Tip of the calyx is what I would like to achieve. So selection of the skin puncture site will depend on whether you want to hit the lower calyx, the middle calyx, or the upper calyx. And 2 planes of the puncture, a TV, is what I will show you in the video. So point number 1, how do you select the skin puncture site? So you put the needle on the patient. This is a prone position. I've just put it on the needle, on the patient. And I take 1 palm and 3 finger breadths from the spine, right? And mark it. This is my posterior axillary line. This is the posterior axillary line. This is the 12th rib, the 11th rib, the iliac crest. This is the head end. This is the foot end. I'm putting the needle again, and this looks good. It is going in the line of the calyx. The direction looks good. So I'm going to enter from somewhere here. From the spine, I have measured 1 palm and 3 finger breadths lateral. I decide the entry by putting the needle in and create a small wheal by saline, or it's just to create tamponade. When you make a small incision, when you do that, the bleeding from the skin is avoided. Now comes the role of the 2 planes of IITV. Plane 1, we already said, is the vertical plane, 90 degrees cut. This is plane 1. And plane 1 gives you the direction, in which direction you have to go, whether you have to go more caudal or more towards the rear end, towards the cranial end, is what the plane 1 is going to tell you. So you put the needle in and you see that you are going a little higher up. You can see that I want to enter this spot, so I go a bit caudal. That I was going a bit higher up. This is not my entry. But by doing so, I'm going a bit lower down. Okay, that is also not a good idea. So I readjust somewhere in between, and I try and go somewhere in between, which is here. And I put the needle right there. It looks good. It's going to hit directly onto the calyx that I want to go. This was wrong. This was wrong. This is good. So plane 1, the direction is already decided by me. It looks good. I put a small incision there, and you can use a marker pen, or with the blood of the patient, you can draw a line. I use the blood as an ink. I draw a line that this is my direction. Now plane 2. Plane 2, I would move towards the foot end, not towards me. Okay? I will move towards the foot end. It goes towards the foot end of the patient, right? And that gives me the depth. It cuts the body in a lateral way, and that gives me the depth. Okay? And I would go in. Direction I already know. I am now by experience trying to go in, but this looks too much deep. So I withdraw and go a little superficial. and push the needle in. The direction already I know. So I go a bit superficial and take a flash of the IITB. Does it look good? Well, it does not look good. It's going a bit higher up. It's going a bit higher up. The first needle was going here, the second one is going up. So again, in between, I try and readjust and take the median path. Direction, as I said, I already know. And I go in, which is the middle path. I check in both the planes, plane 1 and plane 2. It's going at the same spot, and I push the needle, and I feel the resistance of the inner part of the pelvic calyceal lining. These are very fine feel that you go into the renal parenchyma, and you have then finally gone through that mucosal lining, and here you go, you have done the puncture, and by and large, you will get the puncture in a single pass. So this is plane 1 and plane 2 for me. Okay. When I do the plane 2 on my side, I'm taking the radiation on my fingers. And when it comes on my side, it is difficult because the IITB itself is blocking the path of the body. So I have to see it a little below and push the needle. And therefore, I'm not allowed to do a tilt beyond 30 degrees, and which is not going to be always accurate. You have to be, the oblique plane should be roughly 40 degrees. Then that oblique cut really gives you the direction and the depth. The depth is when you go 40 degrees tilt, and vertical plane tells you the direction, the oblique plane tells you the depth, and you go right exactly where you want to go. So that is the triangulation technique according to me. Now, why not the bullseye technique? I already told you that this is not something which is very, very comfortable for me. The fine feel of holding the needle by yourself and holding the needle with the help of a forceps, you are not very, very accurate in the feel that you get when you are going through the various tissues. So that is one negative point of the bullseye technique. And the needle is not seen in its entirety. You know, when you do the triangulation technique, plane 1 is seeing the needle, and like this, the plane 2 is also seeing the entire shaft of the needle. Whereas in the bullseye technique, when you move the C-arm towards you, you are trying to align the tip of the needle to the tip of the calyx, and that aligning is not very easy. Tip to tip is not very easy. The shaft going a bit lower or a bit upper in relation to the calyx is very easy to understand that this is going below and this is going above. So try and remain somewhere in between. So it's very easy to align in plane 2. Therefore, I am a proponent of triangulation technique and not the bullseye technique. However, I have seen experts around the world doing puncture very well with the bullseye technique, and therefore I'm putting this statement: I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times. Practice one particular thing again and again and be a master, rather than trying out different techniques and not being a master. So remember, again, the young guys, failure is essential. If your uniform isn't dirty, you weren't part of the game. All the experts made mistakes. Everybody, when they were learning, there were problems, but you learn from your mistakes, and that is how you build on to your experience. And for, once again, the youngsters, when you are watching people who are experienced, the masters of the game, keep watching them with rapt attention. Keep watching, and you will realize what they are doing. And therefore, for the onlookers who come and spend time a week to high volume centers, keep watching the experts, and automatically you will learn the technique. And finally, before I end, no game was ever worth a rap for a rational man to play, into which no accident, no mishap could possibly find its way. There is no fun in a game which is so easy. You know, it's fun to play a game which is difficult and master it. That is what I'm trying to say. So thank you once again for asking me to be part of this symposium. I will be very happy to take questions if at all. And I'm waiting for my colleagues to have their presentation after me. Thank you.
It's very great and a very useful lecture with a simple introduction. And we have some questions from our audience for you. And first one is, you are well known with your innovating of the ultra mini PCNL, and I have some question, not special question, is and where you got an idea of the ultra mini PCNL?
When I got the idea, it was in 2010. We were doing a lot of PCNL. I started doing PCNL in 1988. I came back from Germany and started doing it, and we were doing the standard PCNL back then, and once in a while bad bleeding, as you all know. So I was getting this feeling that if the dilation somehow can be decreased, the bleeding will go down. But you can't do a small dilation when you want to put in all the instruments. So in a way, this laser helped me out, this optics helped me out. And in 2009, actually, Mr. Scholey, Werner Scholey, the owner of Scholey Company, he was visiting India, and he showed me a mammary ductoscope, a very flimsy instrument. And he said, this is the smallest that I can make. And that gave me an idea that can you make a little tougher one, which can be autoclaved with a good vision. And then that is how the story began. I made the first design, and they made the prototypes, and there were changes, and finally in 2011 the final product. 2012 we put it for CE certification, and we published, and the first paper came up in 2013 March, British Journal of Urology. So that's the beginning of UMP.
Thank you. Second question is, now we all know that now is PCNL techniques is extremely increasing, and I think already maybe more than half of the world now is ongoing to perform supine PCNL, and we also already fully doing only supine PCNL, and very rare case of the with some special case for prone PCNL. So what you think that will bullseye technique or triangulation technique will remain relevant over the time? Because we all know that in the supine positions, the X-ray access is very easy, and it's not takes long time like triangulation or bullseye technique.
Well, we also do supine PCNL, not always. More PCNLs are done prone, but we have done probably more than 100 supine PCNL now, just to understand how easy or how difficult it is, the advantages of it, etc. We use the triangulation technique for supine PCNL as well. The patient is in supine, but the plane 1 and plane 2 remains the same in supine. It makes no difference. So I don't think that is going to change. As far as what do you want? Well, it's a personal choice. And at the end of doing so many on either side, I feel that it's like the right-hand drive and the left-hand drive. People in India, we are the Commonwealth nation, so we are the right-hand drive models, and I think Russia is left-hand drive. Am I correct?
Yeah, absolutely.
Right?
Yeah.
So who is a better driver? Both are good drivers, and we just followed the rules. And I think there are some pluses and minuses on either technique, and that's a subject by itself and can be discussed in the next webinar. What would you want? But as far as the approach is concerned, sonography guided decision, and then plane 1, plane 2, and supine. That's the way we do it.
Okay. Thank you, Professor. It was a very nice lecture again. So thank you for your time. And dear participants, let me introduce our second speaker. He's my friend and the Professor Emre Sener. He's from Turkey. He's assistant professor of the urology in the Department of Urology, Marmara University. He's one of the founding members of the Petra Group, which means Progress in Endourology, Technology and Urology Working Party, which was organized by Professor Oliver Traxler. And he's a member of the Young Academic Urologists, Endourology and the Urology Working Party, which is a substruction of the European Association of Urology. And he is the main focus on the mini PCNL. So today he will talk on the miniaturization of the PCNL. So dear Imre, you can start, share your screen.
Of course. First of all, I would like to thank Azimjon for inviting me to this webinar. It's a pleasure for me to be here presenting about mini PCNL, and it's an honor to be among this precious faculty. I will today talk about miniaturization of PCNL. So I'm an assistant professor in Marmara University, so I'm sending all our greetings from Istanbul. Now, when we talk about PCNL, the nomenclature is a little bit different. You know, I started my education with PCNL in prone position and by doing standard PCNL. But when you first hear the word miniaturization of PCNL, you don't actually know all these details. So what do we call standard PCNL? It's about the accesses bigger than 22 French accesses, and the rest I thought it was mini PCNL, but there are different subcategories like mini PCNL, ultra mini, mini micro. So there are many studies talking about this nomenclature, and it's a little bit vague. But in this review by Panagiotis Kalidonis, which was published in Turkish Journal of Urology, they wrote these classifications in two different articles. So in the first one, as you see above, the standard PCNL is larger than 22 French. Mini PCNL is less than 22 French. So practically, all these MIP, UMP, SMP, they may all be included in the mini PCNL category, but there's this one particular different approach, which is micro PCNL, because the technique is totally different. So, I think we have to know about the history of PCNL, history of kidney stone surgery, to appreciate better the concept of mini PCNL. So before 1950s, it was all open surgery. And in 1882, Joseph Heitrill and Max Brodel described this avascular plane, and all the surgeries were performed by cutting this avascular plane. And the first nephroscopy was performed in 1941 while doing an open surgery. The surgeons inserted an endoscope from the already incised kidney, and they did their first nephroscopy and took out kidney stones. This concept of tapping the kidney started in 1865 when the surgeon repeatedly tapped the kidney of a 4-year-old in case of an hydronephrosis, which resulted in recovery. And the first nephrostomy tube was inserted while doing a renal angiogram. It was inserted by accident, but it provided drainage, and it was in 1955. The first extraction of renal stones through a nephrostomy tract under radiological control was performed in 1976. It was more like a blind technique by only using radiological control. And in 1978, Arthur Smith, as you may call the father of endourology, he first inserted an antegrade Gibbons stent through a nephrostomy, through a percutaneous nephrostomy. And this was the start of inserting consciously something inside the collecting system. And with the collaboration of Arthur Smith and Karl Amplatz, who was an interventional radiologist, many wires, many dilators were developed, and baskets that were used to extract stones in a blind fashion during the 1920s were started to be used with endoscopes to take out stones by directly seeing them. And afterwards, Peter Elkin developed the coaxial telescopic metal dilators so that we could dilate the tracts and proceed with percutaneous nephrostomy. In the initial procedures, the steps were the surgeons inserted a nephrostomy tube, and the tract was serially dilated from 22 French to 26 French over days. So one day they put in a 22 French, the next day they take it out, they put a 24, and the next day they put a 26, and so that they could introduce a 21 French cystoscope through this dilated tract. And the first series, the first publication about PCNL was published in 1984 in the Second World Congress of Percutaneous Renal Surgery. And in this study, the authors presented more than 3,000 cases, and the success rates were more than 90%. So how this mini PCNL started, as Professor Desai already told, it was when people first started doing their PCNLs, it's more a standard tract to insert bigger tracts, to have bigger instruments to take out stones. But how this mini PCNL started? The first case series was published in 1998. It was in infants and preschool age children, and the authors used 11 French vascular access sheet and pediatric endourological instruments, and the authors reported 85% stone-free rates with no relevant complications. And the second case series was published in Journal of Endourology in 2000, and it was Manoj Monga who presented this article with 90% stone-free rates. So the initial publications were full of success, high stone-free rates, and reasonable complications. Then we will go in a chronological order. Then in 2001, another case series was published, and this is the first mini nephroscope that was used in the literature. And stone size was 2.4 centimeters, which is rather large, and the stone-free rate was 100%. But still, the authors commented in this publication that mini PCNL could not replace conventional PCNL because it was not suitable for large concrements. But these are the initial publications. So the concept was more in favor of standard PCNL. Then in 2008, another case series was published. The article was in German. And finally, the authors commented that mini PERC could be regarded as an alternative treatment modality to conventional PCNL. So with time, we will see that the mentality is changing. In 2007, Guido Giusti and his team published this article. It was a retrospective study. The title is Mini PERC, No Thank You. So the stones were less than 2 centimeters. They compared mini and standard PCNL patients. When you take a look at the operative time, mini PCNL is longer. Hemoglobin drop, it's in favor of mini PCNL. Hospitalization rate is in favor of mini PCNL, but stone-free rate was lower in mini PCNL. So Guido Giusti and his friends commented that there is no significant advantage of mini PCNL in this retrospective study. So these are the initial studies, let's say. Then started the randomized, the prospective non-randomized and randomized studies. This is a non-randomized study by Thomas Knoll. They compared mini and standard PCNL. In mini PCNL, tract size was 18. In standard, it was 26. Number of patients were similar. When we take a look at the variables, the operative time and stone-free rates were similar between the two groups. So there is no significant advantage of standard PCNL over mini PCNL. And post-operative pain, when you take a look at this, it's statistically significant that in mini PCNL there was less pain. So the authors commented that both techniques are effective and safe, and mini PCNL provides shorter hospital stay and less pain. Now, with this time, the advantages of mini PCNL were started to be appreciated. Another prospective non-randomized study came from a Chinese team and published in Gold Urology Journal in 2010. The mini PCNL and standard PCNL were compared. Number of patients were similar. And when you take a look at the statistically significant parameters, operative duration was in favor of PCNL. Hemoglobin loss was higher in standard PCNL, and blood transfusions were higher in standard PCNL. But the stone-free rates, in other terms, the success rate was similar between the two groups. So the authors commented that there are no significant, but only a few advantages of mini PCNL in terms of safety. So mini PCNL proved to be a safer operation in despite of its longer operative times. And then a prospective randomized study was published, again comparing mini and standard PCNL. And the green ones are the variables with statistically significant difference. The pink ones are the non-significant differences. So we will take a look at the green ones, and the complication rates, especially the decrease in hemoglobin level, was less in mini PCNL group, and bleeding that necessitates transfusion is significantly less in mini PCNL. So mini PCNL proved to be a safer operation. And when you take a look at the mean operative times, they had subgroups with Staghorn stones, simple renal pelvis stones, and multiple calyceal stones. The operative times were higher in mini PCNL. So standard PCNL provided an advantage in operative times. So the authors commented that mini PCNL decreased bleeding and improved stone-free rates for multiple calyceal stones, but had longer operative times. And with time, now we're going chronologically, these authors compared the mini and standard PCNL in a prospective randomized fashion for Staghorn calculi. So in this study, the authors showed that the clearance after the first session was significantly better in mini PCNL group, and clearance before discharge was better in mini PCNL group. So for Staghorn stones, these authors commented that mini PCNL is safe and feasible, and even better than standard PCNL for Staghorn calculi. And in 2011, another prospective case series was published for stones between 1 to 2 centimeters. And in this study, the authors compared mini and standard PCNL, and interesting variables. When we take a look at the tubeless fashion, mini PCNL ended in a tubeless fashion significantly more than standard PCNL. And when you take a look at the complete stone clearance, it's similar. Even if it's significant, the numbers are very similar. So the authors commented that similar clearance rates can be achieved with mini PCNL compared to standard PCNL, and it ends more frequently in a tubeless fashion, and it provided shorter hospital stay. And another study in 2012 for Staghorn calculi, and it's a prospective non-randomized study. Again, when we take a look at the complication rates about bleeding, the hemoglobin drop was lower in mini PCNL group, and stone-free rates were higher in mini PCNL group. So the authors again commented that efficacy and safety of mini and standard PCNL for Staghorn calculi are not different. So we see that with time, the concept of mini PCNL is becoming equal to standard PCNL. At first it was worse. Now in 2010 and in 2012, it's becoming similar. And we will see with time how it evolves. This is a prospective non-randomized study in 2014, published in World Journal of Urology. The authors took compared mini and standard, the number of patients were similar. And when you take a look at the complications, the Clavio-Dindo grade 2 complications were similar. As you can see, there are no significant differences. The significant differences are the ones in yellow. So the volume of fluid absorbed was higher in mini PCNL group, and hemoglobin drop was less in mini PCNL group. But the volume of fluid absorbed was higher because we probably have higher intrarenal pressures in mini PCNL group. But eventually, when the authors took a look at the sodium chloride and potassium levels, they were similar between these mini and standard PCNL patients. So the fluid absorbed did not change the electrolyte levels. And we go chronologically again. In 2015, a retrospective study was published taking a look at the mini PCNL. And the authors here used a 16 French axis, and they showed complete clearance in 60% of the cases, and the complications rate were very low. And the authors at the end commented that with mini PCNL with 16 French axis can be used in adults with relatively low transfusion rate and high stone-free rate for various types of stones. So with time, people started appreciating more the concept of mini PCNL. And in 2015, a meta-analysis was published. This meta-analysis was performed with 8 studies, comparing more than 300 mini PCNL and 300 standard PCNL. So when we take a look at the tables here, the hemoglobin decrease was in favor of mini PCNL. The transfusion rate again favored mini PCNL. The operative duration was in favor of standard PCNL. But the complications, fever, perforation, and pain scores were in favor of mini PCNL, as well as hospital stay was shorter in mini PCNL. And then in 2016, a review was published comparing these procedures. And here, when we take a look at the second table on the lower end, the standard PCNL had transfusion rates up to 6%, while mini PCNL had transfusion rates for up to 2%. And the indications were similar. So mini PCNL took its place for the treatment of large stones. The limitations of mini PCNL were longer operative times for larger stones. And the authors commented that the new mini, ultra mini, and micro PCNL are safe and effective for small to medium-sized stones. Another series, a retrospective study, was published in Scandinavian Journal of Urology. In this study, the mean stone sizes were larger than 2 centimeters. It's around 4 centimeters actually. And when you take a look at the primary stone-free rates, the stone-free rates were higher in mini PCNL arm, and after a secondary procedure, they were similar, but again, numerically higher in mini PCNL group. And when you take a look at the complications, mini PCNL provided to be a safer operation when you compare it to conventional PCNL. And hospital stay was significantly lower in mini PCNL group. So the operative time, the shorter hospital stay, and the success rates were favoring mini PCNL over conventional standard PCNL. Now, from Khurshid Ghani and his team, led by Jean de la Rosette, in 2016 in European Urology, another study was published. And in the conclusion, the authors commented that mini PCNL has shown a trend toward fewer complications and less bleeding with less analgesic use. And this comes at the cost of a lower stone-free rate and longer operative times. And in 2017, a prospective randomized study was published in Arabian Journal of Urology, comparing the two techniques. Stone sizes were between 1 to 2 centimeters. The green ones are the non-significant, and the yellow variables are the significant variables. When you take a look at the same things, the postoperative hemoglobin levels, the transfusion rates were in favor of mini PCNL. The duration of hospitalization was shorter in mini PCNL, and pain scores were better in mini PCNL group. So the conclusion was mini PCNL plays an important role for stones less than 2 centimeters because it provides less blood loss, shorter hospitalization, and less pain. In 2018, we're coming to our time now. Mini PCNL and standard PCNL was compared in a prospective non-randomized study. The concept of nephrostomy placement was much higher in standard PCNL, so the mini PERC ended in a tubeless fashion more frequently compared to standard PCNL. And hemoglobin levels are again hemoglobin drop was less in mini PCNL, so less bleeding with the mini technique. And stone clearance was similar between the two groups. So with time, with new technological advancements, probably the stone-free rates, the success rates of mini PCNL started to be similar with standard technique. In European Urology Focus, a review was published in 2017, and it was from Silvia Proietti and Guido Giusti. As we can remember, at the beginning of my presentation, Guido Giusti and his team commented that mini PCNL did not provide any advantages, but 7 years after that, here is their review and their comment in this journal, European Urology Focus, and they told that miniaturized PCNL techniques are capable of offering similar outcomes to standard PCNL with lower complication rates in case of medium size. So again, these authors also changed their opinion. They were thinking that it did not have significant advantages, but with time, their way of thinking evolved, and now they see PCNL, mini PCNL, as a similar technique to standard PCNL in cases of medium-sized and hard renal stones. And another review by Sven Lam in 2018. Just take a look at the comment at the end. There is no limitation to the use of mini PCNL. But when we take a look at the chronological evaluation, in 2001, the same author, Sven Lam, in his publication, commented that mini PCNL could not replace conventional. In 2008, the same author changed his opinion just a little bit and told that mini PERC could be regarded as an alternative. But in 2018, the same author told that there is no limitation to the use of PCNL. I think this slide summarizes very well the evolution of the concept. It was not regarded as a good surgical option, but with technology, with time, and with publications that showed the success of mini PCNL over standard PCNL showed a great evolution. A prospective randomized study was published in 2017. The mean stone sizes were higher than 2 centimeters. The operative times were similar between the two groups. But when you take a look at the fluoroscopy time, showed significant improvement in mini PCNL group, and overall stone-free rates were similar again. But the decrease in hemoglobin level again showed a advantage of mini PCNL over standard PCNL. So all the publications along this journey has shown similar results. An experimental study was published in Journal of Endourology in 2018. The authors, under the leadership of Manoj Monga, instilled E. coli into the collecting systems of pigs, and they compared mini and standard PCNL. So at the end, they took cultures from different organs while after performing PCNL in these E. coli instilled collecting systems. They also measured the intrapelvic pressures. Of course, with a smaller tract, the intrarenal pressures were higher in the mini PCNL group, and consequently, the E. coli that was instilled into the collecting systems of these pigs was disseminated into the body, and the cultures were positive in various organs in the mini PCNL group when you compare it to the standard group. So mini PCNL causes more septic complications in infected collecting systems than standard PCNL. What this study shows that as we pay attention to intrarenal pressures while performing a flexible ureteroscopy, this intrarenal pressure concept is important in mini PCNL surgery. And with time, when we showed the advantages of mini PCNL over standard PCNL, and then started the comparison of mini PCNL techniques, such as comparing micro PCNL and ultra mini PCNL in this pediatric population. This was a systematic review, and there were 11 retrospective and 3 prospective studies in this review. And in both techniques, the micro PCNL, ultra mini PCNL, the complication levels were similar, and there were no high-grade complications. And this is a complicated table, but here are the prospective studies. This one, the first one from Selçuk's slide, the third one from Dağgül, and in terms of micro PCNL. And for ultra mini PCNL, the study from Dağ is the prospective study. So the mean stone sizes were similar in all these studies, in micro and ultra mini PCNL. The operative durations were, here it's 72, here it's 71. So the operative duration between comparing micro PCNL and ultra mini PCNL are similar, and the mean length of hospital stays are similar. So the only advantages of micro PCNL is the bleeding complications. When we take a look at here, the hemorrhage requiring blood transfusion is more frequently seen in ultra mini PCNL group. And the last publication that I will show you is a review from Evangelos Liatsikos team led by Panagiotis Kalidonis. Here there are 4 randomized studies comparing mini PCNL and standard PCNL in the upper table, and comparing mini PCNL and flexible ureteroscopy on the lower table. So in conclusion, the mini PCNL provided better outcomes, better stone-free rates or similar stone-free rates to standard PCNL, similar operative times in some publications, but slightly longer operative times compared to standard PCNL. But the hospital stay, drop in hemoglobin levels, blood transfusion, and nephrostomy tube insertion was all in favor of mini PCNL, which eventually put mini PCNL in a place where it is comparable to flexible ureteroscopy. And when you compare it to flexible ureteroscopy, we see a significantly better stone-free rates comparing mini PCNL and flexible ureteroscopy. But again, the complication rates of mini and micro PCNL compared to flexible are similar. So micro and mini PCNL provides complication rates that are comparable to flexible ureteroscopy, but provides better success rates in terms of stone-free rates. So standard PCNL, did it lose its position? It can be performed, especially in collecting systems that are capable of acquiring these larger tracts. Of course, the preoperative imaging is very important. So when you have these kind of tracts, you can go for a standard PCNL, but remember that you may end up with a bleeding patient. But there are cases where it's never possible for you to put in a 30 French or 26 French access sheet. If you want to do multiple tracts, such as in this patient on the right-hand side, or if you have a tight collecting system, such as the one on the left-hand side, you cannot go for larger tracts. So you have to adapt your systems, your instruments, and your technique to a mini PCNL approach. So if you want to take a look at how I do it, I have a YouTube channel and I have some videos over there doing mini PCNL, and also I have standard PCNL videos. You can take a look at my YouTube channel. I thank you very much.
Very good review of the PCNL with another techniques of this surgery. So we have a few questions here, and first one is, do you think that mini PCNL or ultra mini PCNL or microPEC can replace RIRS?
When I was a fellow at the Tönon University with Olivier Traxler, I was amazed by how flexible ureteroscopy was working. But in hands of Olivier Traxler, it's something different. And at that time, I was thinking that flexible ureteroscopy, with all these lasers, with the high-powered 100-watt lasers, I thought that flexible ureteroscopy would replace every case of PCNL. But with time, with my experience growing with all these stone patients, I am now convinced that the most respected surgical approach would be mini PCNL. This is my personal opinion, of course. With mini PCNL, you have less complication rates compared to standard, and very high stone-free rates. Even for very large stones, for Staghorn stones, you can perform mini PCNL with all the lasers, with all the combined lithotripsy devices. And when you compare it to flexible ureteroscopy, it will provide shorter operative times, and compared to flexible ureteroscopy, generally you will be working in a lower intrarenal pressure environment, which will also decrease the septic complication rates. So when you have a small stone and when you have two options, such as flexible ureteroscopy and a mini PCNL, I think mini PCNL in experienced hands may be a better option compared to flexible ureteroscopy. Of course, none of these procedures will eventually fade away. They will all stay, but I think mini PCNL will be on the top of the roof of these surgical options.
So you are in the group of the surgeons who will prefer mini PCNL, right?
Yes, probably. I have patients after, I visit them in the ward after a successful mini PCNL operation. They're telling me, they're half awake from the anesthesia. They're telling me, when are you going to take me to the operation? And I'm telling them it's already done. So with small tracts and with careful dilation and with careful irrigation, in order not to expand the pelvic calyceal system too much, you end up with a perfect surgical outcome. I love the PCNL, by the way.
Dmitry, what you would say about that?
Excuse me.
I am asking our another speakers, Dmitry.
Actually, my point of view, we have respect the patient anatomy, and of course we have to be based on the guidelines. I am for the tailored treatment for each patient. So it could be based upon on the individualized approach, I would say.
Professor Desai, what you will say?
Yeah. I would echo the sentiments of Emre. What happened was, like, if I tell you the story of lithotripsy came in the 80s and everything went on the lithotripter, and then we realized the problems of the lithotripter, that there is Steinstrasse, there is too much of radiation, the stone-free rates are questionable. The same thing is happening with flexiureteroscopy. What looked like a non-invasive technique, what looked like a very innocent technique, is not that non-invasive. There is high intrarenal pressure, therefore high infection rate. There is low stone-free rate. It's a very expensive technique. It takes a lot of time versus a well done miniaturized PCNL will give you a very good stone free rate, lower cost, the operating time is limited, and the morbidity, as Emre said, this exactly happens to our patients also. Immediately post-op, I did a ultra mini in Tenon Hospital. We did a workshop with Olivier Traxa. And the patient, before going in, was speaking in French, and he said that I don't want anything to be done through the urethra. The nurse translated for me, and I said, no, we are doing it from the loin. So don't worry. After the operation, after 6 hours, I went to see him before going to the hotel. And the patient was very angry. He was talking in French and he was telling the nurse, I told you that I don't want anything from the urethra, and you have done the operation from the urethra. So the nurse said, I said, well, the operation was done from here, but the urethra has a Foley catheter, so you feel that irritation of the Foley. What I'm trying to tell you is he had no idea that everything was done from the loin. He just was irritated because his past experience of a flexi was not good, and he was very clear, I don't want. So this is what miniaturized PCNL can give you. The only stumbling block is the ability to puncture well. I tell you, we should be concentrating on teaching our juniors how to do good punctures rather than taking all the stones on flexi-ureteroscopy. The big ones, the flexi is going to stay. Emre, you made a fantastic presentation, a very scientific, fantastic presentation, I would say, giving weightage to exactly what is good for one modality versus the other. It's good for small stones, 10 to 15 millimeters, that's it. Beyond 15 millimeters, flexi, in my opinion, is not a good option.
Thank you.
Can I comment, please? When we had the high power lithotripters, like 100 watts, we were amazed. We started using like 40 hertz and with low to provide better dusting. I never use these. I never go beyond like 15 watts or something, because when you increase that frequency, the hertz, you lose control. It's like driving a fast car. You lose control of the steering wheel. So I never exceed 20 hertz, especially for flexible ureteroscopy. And I never increase the energy beyond 1.5 joules, even for PCNL. So you don't need these high power lasers. You can fragment, you can clear any type of stone with low power lasers. And for flexible ureteroscopy and also for PCNL, these are useful, the low power lasers. But when you have something new, you're amazed at the initial step. But with time, you understand that this is not the best option. I think for what happened with larger stones and flexible ureteroscopy, this was the concept. With time, we understood that, of course, you can do larger stones, you can step the procedures with flexible ureteroscopy, but with mini PCNL, it's better in various ways. Also, when you take a look at someone experienced doing a flexible ureteroscopy, this was my intention. When I first went to Tenon, we were watching Olivier Traxa, and we were thinking like, this is easy. This is rather easy. Why shouldn't I do it? And there was another specialist, the chef de clinique in Tenon University. We watched his operation, and it was nothing similar to Olivier Traxa. And when I first took the flexible ureteroscopy on my hand, it was disaster. So it is not as easy as it looks when you see an expert. And also, if you're not that experienced, what you try to do is to increase the pumping and increasing the pressure a lot. And if you're not that experienced, I think the worst thing that you can do is to force. If you have a tight ureter and if you want to achieve something, and if you're not that experienced, you try to stick the instruments into the patient. But ureter is very fragile, and you have to respect the ureter. And doing something, putting something inside the ureter is what's frightening me, because you may end up with tears, you may end up with perforations, with long-term strictures. So these are a little bit underestimated in flexible ureteroscopy. But with PCNL, you have a very tiny hole in the a controlled perforation in the parenchyma, which heals fantastically, which heals perfectly. And the advantage of mini PCNL was showed this way. When you dilate the parenchyma, after 16 or 20 French, there's an uncontrolled tear in the parenchyma. But in mini PCNL, with the tracts up to 20 French, it's a controlled perforation, so the bleeding is really significantly lower than these large tracts. Of course, there's an urge to put in a 30 French access and take out the stone and end the operation in 20 minutes, but you will end up with a bleeding patient. So you have to compromise a shorter amount of your time and go with a safer operation, which provides a fantastically good stone-free rate.
Thank you. I remember the Professor Desai have very good presentation about the size of the sheet and the damage size of the kidney. I remember, and I hope in our next webinars, maybe we will invite him to show this great presentation. And here is the next question. Is there any significant difference for you between metallic coaxial dilators and serial amplas dilators? Which one you prefer?
I learned standard PCNL in prone position, and I learned dilating with metallic telescopic dilators developed by Peter Alkin. But now I am using single-step dilation with fascial amplets dilators, and I am doing all my cases in supine position, and I'm doing like 98% of my cases in mini PCNL technique. And the advantage of single-step amplets fascial dilators is reduced radiation exposure. But there's an advantage of metallic dilators. The advantage is that when the kidney is mobile, the first introductor of the metallic dilators provides a very provides stability to go into the point that you want to go. And when you hold it still, so the dilation after that point is very stable. You put a small pressure from the abdomen of the patient to decrease the mobility of the patient, the kidney, and then serially you place the dilators, and that provides a very stable, very good dilation. But of course, when you first start these operations, you tend to press the pedal every time you put in a dilator. But with experience, you press the fluoroscopy pedal like after putting 2 dilators, but that's not important. The scientific evidence shows that the single-step dilators provides less radiation exposure, and people are using that. I'm not using balloon because, to be honest, I don't have the balloon dilator for mini PCNL, but it's more expensive than these other procedures.
And the last question, it's brief information from you. Someone asking about what is the main goal of the Petra Group?
Petra Group was founded in 2015, the summer of 2015. It was many of you know Olivier Traxler. He's a very intelligent, wise, modest, and an innovative man. He loves working with the younger generations. So we're like friends with him. And in 2015, he called up 15 of his past fellows. He put us in a room and he told us that we could work together. And with all the enthusiasm that was growing up in that room, we formed this international collaboration group. I think the most important thing with the international collaboration is, apart from scientific evidence that you build up. It's the friendship, and we're like family now. We miss each other, we want to see each other, and we organize these meetings every year in a different country. We gather in a room and we talk about scientific ideas, how we can do studies, and afterwards we spend some quality time together. And I think it's the most important thing, being this close with friends who share the same enthusiasm for stone diseases, and being able to also work throughout the whole year. And when I have a patient, for example, I cannot decide on which treatment. I just text Petra group on WhatsApp and ask their opinions on any topic. I know that my friends, my endourologist friends, are there for me to provide some good quality ideas for me.
Thank you, Emre.
Thank you very much.
So finally, I will introduce our third speaker. He's Professor Dmitry Ergakov. He's a PhD urologist and he's associate professor of the Department of Urology and Andrology, FMBC, named after Burnlazian. He's one of the most experienced experts in the field of the urolithiasis and BPH. We all know about him. So today, his topic is the most challenging topic, I think, is micro-PCNL state of the art. So, dear Dmitry, it's your time. You can start.
First of all, I would like for the invitation for organizers, and I would like to thank my colleagues who made their marvelous presentation with a good practical and academician explanation of many things that I was going to discuss. So for me, it would be much more easier to share our experience in micro-PCNL, and I discussed the technique, our results, our complication, and our point of view for maybe previously discussed topics. I am going to share with my screen. The topic of my presentation is micropercutaneous laser stone management. Yes, below you can see the picture of the hospital. This is a Plitnov City Hospital. There I'm currently work, and this is a large municipal hospital. The urological clinic consists of 60 urological beds. Our chief, probably all this is his iconic person in urology, Professor Alexey G. Martov, head of Russian Society of Endourology and very famous expert in the field of endourology and especially of percutaneous stone management. Yes, and the second thing is that we are one of two main centers in there. Thulium fiber laser is currently employed. Since 2016, we are working with thulium fiber laser, and we have pretty high experience with the cases, and my presentation will be also dealing with the question of the thulium fiber laser. Together with my colleagues, I am going to share with you our experience. Okay, let's move to the first slide, and the name is The Wind of Change. Probably all you know famous hits of German group Scorpions in 19th century 88. They have sung these hits at a large stadium in Moscow. Yes, and there was means that time of innovation. Now it's called perestroika with former Soviet Union President Gorbachev. It was meaning for all of us many changes. So these changes has been done also in the stone management era. Just half of a century ago, there are only place for open surgery. Yes, with innovation, with the start of shockwave lithotripsy, many things have been changed. Yes, and after the introduction of endourology, such as conventional PCNL and rigid ureteroscopy, the frequency of shockwave application has dramatically diminished, and now in the year of 2021, it's approximately 1/3 cases. In our clinic, we have a nice shockwave station, and of course, there are a lot of urgent indication for shockwave lithotripsy, and it's still efficacy. And I would like, as an example, I would like to show the review from the urologist. If someone from us would have a ureteric stone, which type of the modality we will be choose, and almost no one have choose ureteroscopy. All prefer shockwave lithotripsy. So there is still place in the stone management. Of course, now in the era of laparoscopy, many cases, especially simultaneous with reconstruction, could be also done, and there is also a place for laparoscopy. Yeah. But now with a mainstream, I would like to highlight mainstream in the stone and the urology. What we prefer, what factor are favorable. Of course, less trauma, and previous speakers has already discussed it. We need effective tools, and not. I'm not talking only with a laser. We probably such tools, such. Motherless things from EMS company Trilogy with a ballistic innovation, with a ballistic lithotripsy, and also shock pulse is a technology which comes from Olympus company, and there are plenty other marvelous things which could be effectively crash the stone, and not only the laser. Yes, but of course laser is now a gold standard, and of course controlled laser stone treatment is a mainstream. Is a must. Increased role of ureteroscopic stone management has already been discussed with my second colleague, yes, and of course with a person, with an iconic person of Professor Traxer, who also came to our clinic and showed us how he managed with large stone burden. He managed in our clinic 3 centimeter stone burden from below. So it was, but he handles with flexible scope very fast, and I would say no one surgeon could repeat it. And the things that he could perform from below, this is not for all of us. Mini, ultra mini, and micro PCNL, yes, these modalities are current challenges for in comparison with conventional PCNL, and of course more indication, and of course the last but not least thing is combined endoscopic intervention from below and percutaneously. And the other interesting thing I would like to then I talk about tailored treatment. You see from the left side the stone we have often meet in the last century. There was a large stone burden, large Stockhorn. Please, of course, Professor Desai maybe has enough such cases, but in Moscow, in Russia, where there are only few cases in a year with Stockhorn. More often we see stone in the renal pelvis, which does not exceed, I would say, not 15 but 20 millimeters, or even calyceal stone. I mean, not only low pole calyces, but calyces in the other location is also often because why it's happened, because our patient need predictable result, and this is an issue. That is why there is a strong tendency to perform more urological interventional in comparison with shockwave lithotripsy. Here you see probably well-known data from Thomas Knoll, which has been published in 2013. In there discussed the limitation of retrograde intrarenal surgery. Yes, Dr. Tener has already discussed the difficulties with handling of a fiber scope. So you see the unfavorable factors for transureteral stone management. You see the blue line. This is the angle, with a sharp angle. This is unfavorable factor. With a red line, you see the calyceal width, and black line. No, I'm sorry, this is mistake. Length is red line, and black line is calyceal width. And of course, stone size. Of course, well-known limitation of retrograde intrarenal surgery. This is a picture of Italian and urologist Emanuele Montanari, who made his marvelous presentation regarding mini PCNL in 2018. 3 years ago, actually, it was at the European Urological Association in Copenhagen. Yes, and it has compared. He has compared these techniques like famous Russian toys. It's called matryoshka. The thing is that the smallest one is located in the bigger one toys. That is absolutely suited with this idea, absolutely suits with PCNL track classification. If something goes wrong or picture is not enough quality, you can easily move to the another technique and place large bore sheath and continue the operation. This is actually very important. The definition for mini PCNL, actually, I was going to discuss it, but my colleagues has it already done, and actually, I would like just to point out that our Professor Desai was one of inventors of ultra mini PCNL. Yes, and in my presentation, I would like to talk about micro PCNL. That is actually the smallest technology, which employs 4.8 French sheath, and a possibility. There is a possibility of mini micro PCNL with a sheath of 8 French. Why miniaturization of percutaneous surgery is so important. You see, and you have already discussed the issues about the invasiveness of larger tract. Yes, because due to the hemorrhagic complication, of course, and the policy that we have in our clinic, if we see some bleeding from the tube after the operation, we just clamp nephrostomic tube. If it not works, we transfer patient to the angiographic station, and angiography will be provided. This is we anticipate we want to until hemoglobin drop, or if a clinic of anemization appears. No, we instead of we transfer the patient to the angiography, and normally it's work very perfectly. Yes, and when we are talking about blood transfusion rate, you see when we employ smallest tube, it's actually there are no bleeding at all. And as Professor Desai mentioned, many patients feels after the operation only irritation from a urethral catheter, and no pain, no low back pain, no local symptoms. This is actually very exciting. I have already mentioned our collaboration with thulium fiber laser. As far as I learned from the manufacturer, thulium fiber laser is also long available in India. And I don't know how about Turkey, but in India it's still available long time. And the technology exists that this type of laser is 4 times, I would say, more powerful in terms of stone dusting. Why it's happened? Because the peak of absorption is much more closer than holmium-1. And the other thing that actually the durability of the laser, it's a solid laser, and it could be easily transported from the one OP room to the another room. And I know the stories about sometimes the device has fell down from the OP table, and after that it was still working. It's absolutely impossible with a holmium-YAG laser because it contains water, and any transportation has to be made by the technicians, and this is very, very important. Of course, I don't discuss safety because actually holmium-YAG laser is also safe, but in terms of stone treatment, I think the future is for the thulium fiber laser, that's for sure. And of course, you have already mentioned Professor Olivier Traxer. He's also one of the innovators of this thulium fiber laser. In European country is known like Saltiva from Olympus. This is this slide, this picture. It comes from also Professor Olivier Traxer, and was published in 2013. There is an explanation why stone burden size is the limitation for laser stone treatment. We have to be very patient when fragmenting or dusting and managing the stone. So you see stone with a volume 2 cubic centimeters could be has to be fragmented into 64 fragments on 5 millimeters, and if we employ sheath more than 15 French, and if we employ sheath more than 9 French, stone of 3 cubic centimeters needs to be fragmented on 260 fragments. This is or 1,000 fragments. From one side, we need good dusting modalities, very effective, very fast. Yes, and the other drawbacks of holmium yak laser, this is the energy loss. Of course, with recent innovation with Moses technique, the manufacturer partly found the solution, but it's very costly, it's very expensive. With thulium fiber laser, we have no such issues. Yes, micropair polydiagnosis is a disposable set, and actually this is a limitation due to the additional cost. But the technology is very simple. Yes, and the technology employs all-seeing eyes with good quality pictures, and the set it's not very much differs from simple percutaneous tube placement. But the advantage is that all-seeing eyes, it's called all-seeing eyes, needle, and it's very more, I would say, effective because we could see exactly the place that we punctured. I'm going to show you a video after that, and so you could see it. Next slide is the comparison. Actually, this is a recent, the newest one, meta-analysis, which I have found at PubMed, and with a comparison micro-PCNL versus retrograde intrarenal surgery. And actually, the findings, the conclusion are very interesting. But before, I would like to briefly report you about it. 5 papers have been included. Yes, one pediatric group. You see, this is from 2016, and the stone size there was equal, and both were a little bit more than 10 millimeters, but have not exceed 15 millimeters. Yes, and most interesting things, stone-free rate. There was in favor of ureteroscopic stone management, and complication too. So when we compare technique, the main issue of main limitation of micro-PCNL is the stone-free rate, because there is no way to evacuate dust or fragments. I would show how we manage this issue. So actually, this is an operation picture. The patient is positioned in supine with a roller from ipsilateral side. X-ray puncture has been done, but with the assistance of all-seeing eyes. You see, and previously we place urethral access sheath instead of urethral catheter. Normally we place urethral catheter. It allows for visualization. Now you see how all-seeing eyes needle works. So perfect puncture directly through the calyx. Yes, and you see the stone, very nice view with continuous irrigation. Yes, and the harvested dust is the patient obtain this sense, this dust exactly after the operation, and it could be collected for the analysis. This is an advantage. Yes, the peculiarity of laser stone treatment is that we have to every time move around the stone in order to speed up the fragmentation process, I would say. So now we are going. Yes, next slide. Patient and stones. 99 patients have been collected, more women, 56, and the mean age was 47, yes. Stones, the mean stone size was approximately 14 millimeters, yes, and not exceed the upper limit was less than 2 centimeters. Yes, the density was about 1,000 Housefield unit. Stone size less than 15 millimeters was in 58 cases, and more larger stones were observed in 42 cases. Yes, single stone were in approximately majority of cases, 79, and in 21 patients there are multiple stones. Below you see the main radiological steps of the procedure. You see, I show you with the mouse. This is a urethral access sheath, yes, because most of patient has stent before they presented, yes, and urethral access sheath could be easier placed, yes. If no, of course, urethral catheter, yes, you see the puncture, and after X-rays, after the laser stone management. This is a comparison of a mode of different type laser. Of course, you don't need high power laser to manage stone. But if you are going from below, high power holmium laser offers more treatment modalities, I would say. So we have to take it into account between the competitors in this field. Yes. Now there are three generation of thulium fiber laser. In this paper, we have employed second generation with a peak power of 40 watts. It's absolutely, I completely agree with my second colleague. It's absolutely enough for effective stone management. Yes. Our results, only in order to spare time, I would point your attention only to the statistically significant result. It has been shown only in cases if we use urethral access sheath. Yes, the other modalities, other factors like stone size, like working access sheath, like type of employed laser, did not show it any statistical significance. Our intraoperative data, the OP time was about half of an hour. Now, in 4 cases, we use second endoscopic table and provide with combined endoscopic operation. Actually, this is important. This is very important when we, before the operation, consider and consult 3D CT scans. The decision has to be made before the operation and not into the operation, because we have to plan our OP time, OP scheduler, and of course financial, the use of additional equipment increase operation cost. Yes, second micro PCNL access has been done in 5 cases. Conversion to mini PCNL, exactly about it mentioned Professor Montanari. Yes, matryoshka technique, I would say, in 1 case. Postoperative drainage, predominantly in all cases, tubeless technique have been done. Yes, no bleeding, no nephrostomic tube, just the same as Professor Desai mentioned in his masterclass together with Professor Traxer. Post-operative data, overall stone-free rate was achieved in 89%. Prolonged hematuria with Clavien-Dinder 2 degree in 4 cases, fever 7 patient, urgent stent placement due to repeated pain 3 cases, additional shock wave lithotripsy in 7%, second hospital admission in 1 case, and hospitalization length actually due to our reimbursement system is not so important factor, but it was less than 3 days. And of course, combined and the urological treatment offer much more treatment modalities and much more. This is the future, but it needs to be planned before the operation. 2 surgeon, 2 screens, 2 table. So of course the stone-free rate is much higher compared with both approaches as one treatment, but the cost also pretty high. And as a conclusion, I would like to repeat the thing that I have previously highlighted. We need tailored approach based on the guidelines, on the patient's peculiarities, patient's anatomy, and our expertise and the equipment of the clinic. I would like to thank you for your attention.
We have questions, of course. First one is any choices for irrigation, any special choice for irrigation during the surgery? It means any special requirements, or do you use like self-controlled irrigation, or do you need some automatically?
Normally we use gravity irrigation in such, when we employ micro PCNL, we use so-called Traxer pump from Rocamed. It's available on the market, and we use it just the same as you probably you saw urethral access sheet. It's also from Rocamed. But it's actually the sheath trademark that doesn't matter, of course. But the gravity, we didn't employ controlled irrigation.
Okay, thank you. The next question is breast stenting is mandatory for the surgery?
If we would like to use urethral access sheath, actually yes. In these cases, we have used 10, 12 French urethral access sheath, and of course, from the point of view of a safety, of course, one-step urethral access sheath placement without preoperative stenting, it's sometimes it might be from one point of view tricky, and from another point of view harmful. It could lead to urethral damage. Probably all of you saw pictures with urethral access sheath associated damage from Professor Traxer with classification of it. If we use urethral access sheath, breast stenting is mandatory. If no, urethral catheter is enough to provide continuous, from one side, continuous irrigation, and from the other side, decrease intrarenal pressure in order to avoid inflammatory complication.
Okay, thank you. And here's another question about the cost of this procedure. Is it different with, for example, with the another types, for example, ultra mini or mini PCNL? Is it cheaper or expensive? All
of course, it brings additional cost because the equipment is disposable. Of course, this is a limitation. It's a well-known limitation of this technique. Yes.
Okay, thank you. And the next question is about stenting after surgery.
Mm-hmm.
How long time and you put stent, and or is here any chances to finish by tubeless, total tubeless?
Oh, tubeless technique. There were no nephrostomic tube at all, of course. How we decide place mono-J ureteral stent, so-called external stent or internal. Of course, if we use urethral access sheet, in all cases, we put double J stent because all of us would like to sleep during the night well, and we anticipate night calls from the emergency department. The other issue is why stent is better, because sometimes the patients suffer from repeated renal colic. If we perform ultrasound, we almost never detect pelvis dilatation. But the pain is sometimes intractable, and in 7 cases we have put after the operation double J stent. Sometimes it's important. As for the duration of the stent placement, it's actually if we sure that the patient is stone free, we could take it, remove it at 4 or 5 days post-operatively, and that's all. We don't need to place stent for a long time. I mean 4 weeks or maybe some other things, just to improve the pain control after the operation, I would say.
Okay, thank you, Dmitry, for your lecture. And I hope today all our participants enjoyed our today's webinar, and with 3 great lectures and with their big experience in the field of PCNL. So I would like to thank to all our speakers from myself and from our team, the BRIDGE project and Euroweb and the Russian Urology.com. We will wish you all the best in your future practice, and we will wait from you some new technologies and the new big news in the field of endourology. Thank you very much for your participants and for agree to take a part in our today's project. Thank you.
Thank you. Thank you.
So, and you can connect also through social media, and we will be happy to have your proposals. So thank you all. Thank you for participants, and have a good weekend. Thank you.